Cyrus. It's good to be sitting next to you for a
Yes.
change instead of through the digital ecosystem
First time in
between
several
us.
years, so it's
Yes,
good.
since Nashville, Tennessee, where we used to live together.
Yes.
Now, um, now you live there solo. Um,
Now I'm in the World City,
yeah.
and I don't know if I can survive any more days, but
Yeah.
slowly I'm making it.
I mean, mid-August is a tough time to come into New York City, as you say. The trash stench is at an all-time high. Honestly, the entire year. This is probably about the worst week. Like
Oh,
that
really?
mid-August is the end of August is just kind of noteworthy for just like it being just terrible, terrible smells. Anyway, so we are going to have a little chat about prior authorization.
Yes.
There's been some new regulation that was recently released as it pertains to digitizing prior authorization. And so, we're going to talk a little bit about how that will potentially impact the prior authorization landscape. We'll hit on what prior authorization is, and then kind of get into maybe some more nuanced technical conversation at the end that some folks will probably be tuning out for. So does that
Yes.
sound good?
Yeah, if you're an interoperability nerd, if you love federal rules and the nitty gritty of rulemaking, then stick around for that section. But we'll try to keep it high level and very accessible for the beginning portions.
Cool. So to start, Cyrus, I'm going to cue you up and ask you kind of just walk me through what is prior authorization and why is it so frustrating?
Yeah, so prior authorization is probably something that a lot of folks are already familiar with, but just to cover it, it's a process that we have within healthcare, within American healthcare, where, essentially there's a review of certain procedures and medical services to ensure that they meet medical necessity and that an insurance company will pay for them. So it's an attribute of having health insurance and using health insurance to pay for those services. If we all sort of paid out of pocket completely for our medical care, which is a pretty challenging thing to do given how expensive it is. But if we did that, we would not have prior authorization at all. It would just be a matter of going out to the grocery store and buying a box of mac and cheese, the same kind of idea. So you have this whole process where you submit details to a payer about what procedure is going to happen, and they vet that and make an assessment for whether they'll cover it or not, and whether they feel that it's medically necessary. And that's a really frustrating process because what you're basically saying is, as a payer, hey, treating provider, I don't necessarily trust your clinical judgment to be perfectly correct. You might be trying to do something that's not totally appropriate or that I'm not going to cover. And so you need to let me know about that ahead of time and get my approval. For providers, I think it feels like a questioning of their medical judgment and their expertise. And then, of course, becomes kind of a turf war, if you will, between the providers and the payers. And that leaves patients stuck in the middle trying to just figure out how in the world they can get what they need. It also stinks for patients because we are paying for our health insurance. We're paying really high premiums. At least I'm paying really high premiums every month. And so we expect to get the services that we are paying for. We expect to get the coverage. It's kind of like we have car insurance, right? And so if you have an accident or something like that, the car insurance is supposed to cover. It's kind of, a little ridiculous for the insurance company to say, like, oh, no, we're not going to cover that. Like, you don't need, this, bumper to reattach to your car after it got knocked off.
Right. If you bring the car to the mechanic and the mechanic says, yeah, this car is done for, like
Yes.
you need to get a new car, or like you need a new engine.
Yeah.
And then your car insurance says, oh no, you don't need a new engine. Your car is fine.
Yeah, you can make
like,
it.
You're like, who do you trust, given that you've been paying all this money to the car insurance company for exactly this situation?
Yeah. Or they might say, before you get a new engine, first try this bicycle. So that's an attribute of prior auth as well in medicine, where, especially for drugs, they'll say, don't try this, new expensive therapy. Try this other thing first. And, it's called step therapy, or, providing a substitute of some type. So that's something where I want to be clear. We're not making a judgment one way or the other about whether prior auth is a good or bad thing. We'll leave that to the payers and the providers to duke it out. But it's absolutely a frustrating thing because, okay, yeah, there's this aspect of like, back and forth and having to jump through those hoops. But then the process itself is really aggravating, I think, for anybody. And that's probably a neutral statement when you know that prior authorization often involves very paper-heavy, antiquated processes. So you're calling people, you're faxing forms. You are checking online portals and logging things. And you're doing this differently potentially for different payers. So it's not like there's one consistent place to go to. You have to know the right way to do it for each one. And then, you may have to even mail some stuff in. So, and then the time it takes to get a response back, it can take 2 weeks and take longer. You hear about people in the news and other things. They have stories. It's anecdotal, of course, but there are stories out there that a lot of people share about having care delayed because they're waiting for prior authorization or something was denied by the coverage was denied by the insurance company, and so they're fighting that and trying to get approval so they can move forward. So all these things compound to just make prior authorization, one of the most despised processes in all of healthcare.
Yeah, and just to put some slightly more quantitative numbers to that, there was recently a study published by the American Medical Association saying that 94% of physicians reported care delays associated with prior authorization. 80% reported that issues related to prior authorization process can sometimes lead to treatment abandonment entirely. So it's a really significant issue in terms of the patient actually accessing the care that they need. And then on top of that, the costs, the administrative costs, the burden to particularly these small provider offices where this is a significant portion of their expenditures. A number of provider offices reported having people on staff specifically managing prior authorization processes.
Yes. But I think, Sam, too, so you talked about like all this time spent and such. But then people often find, I think, that when stuff is denied and then they try to appeal it, they end up getting approved. So it's like, why was it denied in the first place?
Exactly.
What's going on here? Why are we making it so hard on ourselves?
Yeah, there was recently a study released that 81% of claims, prior authorization requests that were initially denied in Medicare Advantage claims were then approved when they were resubmitted on appeal. Wow. There's a really high number, right? Yeah. Either there's some, very uncertain responses, assessments going on compared to the clinical standards that are, that doctors are using to determine care, or there's some really, poor algorithm that the insurance plan is using to assess these claims.
Yeah, so to give an analogy for the folks watching, imagine going to the grocery store trying to pay for your groceries with your credit card, and your credit card gets declined. And so you have to go and log into your app, or maybe even call your card company and say, hey, what's going on? I want to pay for my groceries. And they say, oh, okay, try again. And so then you have to try again, and 80% of the time it works. Right. Why'd you get denied in the first place? You're just buying groceries.
Okay, so now let's move on a little bit and talk about kind of how potentially digitizing this process could have an impact.
Yeah, because I think there have been some new regulations and stuff like that. So do you want to talk about what in a fully maybe digital world this kind of looks like, and how would any of those pain points that I talked about even be addressed?
Yeah, well, let's start. Let's say we were talking earlier about what you were planning on eating here in New York City. And, I thought that it might be helpful to kind of go through a hypothetical example of how a prior authorization is executed today without, kind of primarily electronic exchange of information, and then kind of compare and contrast to how it might be in a future state. So Cyrus, Cyrus is to some extent my guest here in New York City, which is my hometown. One of my favorite parts of living in New York is that you can get a pastrami sandwich of the utmost quality.
Yes, those have been good, but they've caused some problems, Sam.
Right. So let's use a hypothetical.
Okay. All right.
And say that poor Cyrus comes to New York City. As far as I know, this has not happened in real life. He comes to New York City and he just can't get enough pastrami sandwiches. He puts down 3 Katz Deli pastrami sandwiches.
This is not in any way, we disclaim any sort of, issues with cats. So I want to be clear, we're not suing anybody. Want to get that out there.
Unfortunately, Cyrus has to go to the urgent care or even an emergency room to get assessed because he's not feeling well after his 3rd pastrami sandwich.
Yes. And it was not good news, folks. They said, all right, you're not going to die. That was the first thing they said. So that was good. But you need to see a specialist immediately. Yep. So I did that, and it sounds like I need a procedure to get over my pastrami situation.
Right. But of course, that procedure can't just be done and later approved by your health insurance,
Oh,
which
yeah.
I'm sure is very high quality health insurance. Your provider has to first submit a prior authorization on your behalf.
Yep.
So how would that go? How would they go about doing that today?
Yeah, I mean, again, like I said earlier, it's going to be a pretty manual process. So what they're looking at is, okay, they make this clinical assessment that I've got a pastrami issue. I'm guessing, I don't know what diagnosis, like ICD-10 code that is, but it's got to be in there somewhere. Initial encounter, though, not subsequent encounter. So got that issue. So now they're going to have to figure out, okay, first of all, is prior authorization needed? They would need to check that unless they already know. But then what kind of documentation do I need to provide as a clinic to be able to get this approved? So they'll need to call the insurance company or take a guess or look at an online portal with some guidance. They would have to try and figure out what is the necessary supporting documentation that has to be provided. Then once they gather all that and they figure out where do I go and submit this request as well, is it an online portal? Is it a phone call? Is it a fax? Then they go through that process of submitting that information, and then it becomes a waiting game. Like we talked about with potential delays to care, you're looking at sometimes a quick approval or a denial, but sometimes waiting weeks to be able to get an answer. And it could be possible that as a clinic, you have to follow up with your patient and say, hey, sorry, we're going to have to delay this procedure because we're not able to get approval just yet from the insurance company. It's going to be a little bit longer. So that's a challenge. I think, thankfully, I've got some time for my pastrami-itis, but for other folks, there are some very serious things where time is of the essence.
Yeah, and you think about a patient with cancer.
Yes.
Desperately needing chemotherapy. You talk about stage 3, stage 4, where like those 2 weeks really makes a big difference.
Mm-hmm.
And not only do the provider office has to call the insurance company, figure out who to talk to understand whether or not a prior authorization is required, exactly what documentation needs to be submitted. They then oftentimes will actually put that documentation in the mail, in snail mail, or, even at best a fax.
Yep.
Only 35%, as of a recent 2024 study, only 35% of prior authorizations were submitted fully electronically.
Wow.
Which is a pretty low number, particularly given that when you talk about claim submissions, almost I think upwards of 97% of claims are submitted electronically.
Absolutely.
But prior authorizations are much more uncommonly submitted via electronic means.
Absolutely.
So this has real ramifications for real people.
Yeah, and once there is a decision, there's again a phone call or some type of response fax or something like that, and that decision might not be in our favor. It might be that there's a denial, like you talked about, and
commonly, particularly when you talk about really expensive medications and chemotherapy, that happens all the time.
Absolutely, and this is, I think, an objective thing to say. It is in the payer's interest at times to deny coverage for a particular procedure because at the end of the day, they make money. This is just an objective fact by taking in more dollars through premiums than paying out in claims. And so at the end of the day, their incentive is to, provide that margin by scrutinizing very closely certain, especially high dollar procedures. If you get a decision, but it's not in your favor, now you go through this appeals process, and it's more time and more paperwork to go through that.
Right. So back in snail mail, how fast does USPS get your appeal to the insurance company? It all just takes time. Meanwhile, the patient is suffering.
Yeah, absolutely. So that's like the existing flow, and again, very much not 21st century. Very much not leveraging a lot of technology. At least at the moment, something where it's an opportunity to make a huge amount of difference. I mean, think about something that can be fully digitized and how much more efficiency can be gained from that process. And frankly, it takes, I think, to an extent, government regulation to play a role here and to provide an incentive for these players to move to a digital or mostly digital process. And there's been some regulations that have come out recently, right, Sam? That's going to make a difference, we hope?
Yes, there's a slow drip, but at this point we're making a lot of progress, I would say. So first of all, just to kind of set the scene, there have been on the books for a number of years very specific regulations around how to submit electronic prior authorizations. There's a HIPAA requirement that if electronic prior authorizations are submitted, they're done so in a particular standard called a X12278 file. But that does not require that any player in the prior authorization process actually submits or makes available coverage information or documentation requirements electronically.
Yep.
So as of the last couple of years, there's been a couple of really key pieces of regulation that have been passed. The first one, published by CMS a couple of years ago now, is called the Patient Access and Prior Authorization Final Rule. Shortening the full name a little bit, but essentially what it is. And that rule requires that, quote, impacted payers, which are a number of types of health insurance plans that are to some extent overseen or overseen by the federal government.
You're regulated in some way.
Regulated in some way. So we're talking about Medicare Advantage, Medicaid. We're talking about, federal government, federal exchange regulated insurance plans.
So the ones that are on the marketplaces, the federal marketplaces that you might go out and buy as an individual. Right. I think also like CHIP programs, like the Children's Medicaid type programs. So basically anything that federal government has a big hand to play in, which is not necessarily, it's a big chunk of health insurers, but it is not necessarily, totally comprehensive. You're not talking about traditional Medicare, which has a small portion of prior auth currently. We'll see if that changes in the future, but they do have some prior authorization, as well as, self-insured plans from employers. And those types of services that a lot of folks who work at big companies have.
So impacted payers, which 60 to 70% maybe of the full insurance market are now going to be required. This kicks in 2027 to support electronic prior authorization, and that includes a number of components. The first is the ability of providers to check whether or not a particular surgery or service is prior authorization is required, right? The next one is to determine the documentation requirements to submit a prior authorization. Again, all things that have been previously done via phone call or, in some cases maybe a portal, but it's still a slow process.
Yep.
And then finally, the ability to actually electronically submit these prior authorizations, receive a response, and also kind of manage the status of these prior authorization requests, get an outcome.
And then doing all this stuff through more modern technology, right? So not necessarily that standard you mentioned of X12278, which is a little bit older, but leveraging FHIR APIs to be able to do that.
Yep. And interestingly, and this is where we'll kind of talk a little bit later, CMS was not prescriptive in the mechanism by which these impacted payers support these requirements. So there is some flexibility for how they support these requirements.
Gotcha.
In contrast to the most recent piece of regulation called HTI-4, which was just released and passed a couple of weeks ago. And that piece of regulation was more focused on the health IT used by providers, by doctors, right? So there is an existing certification process for health IT, primarily electronic health records, but also practice management systems and some other, health IT that can be used by doctors and other, provider offices, hospitals, and up until now, there was no hard requirement that those electronic health records and other health IT support the electronic exchange of prior authorization information. And so that is what has changed as part of this HTI-4 regulation. So kind of corollary to the requirements passed for payers, health IT used by providers are now going to have to be able to successfully request the coverage information for a particular item, service, surgery. They're going to have to be able to request the documentation requirements from a payer's health IT, and they're going to have to be able to actually receive prior authorization requests and responses, as well as, outcomes and status checks.
Yeah, it seems like, these things had to kind of go together, like two sides of the same coin in a way. Like imagine in a world where, there's a country that wants to move to a cashless society. Well, first they might say like, okay, you got to have, the credit card companies have to offer these secure credit card networks and payment networks where we can have digital transactions. Okay, great. But then if you don't require the merchants to then, accept credit cards and only take credit cards in their day-to-day business and transactions, then you wouldn't be able to fully enforce that ecosystem of a cashless society. So that's kind of how I look at it, is like we had to have the payers offering these APIs and offering ways to tap into the data, and you've got to have the EHRs to also be able to support accessing and tapping into those APIs.
Yep. So that's kind of where we are. So I think in theory, once these requirements come into effect, there is the potential for many more of these prior authorizations to be submitted and responded to electronically, which I think we agree is a very positive thing in terms of patient care, in terms of reducing administrative burden on physicians. This is all, I think, a pretty positive thing. Mm-hmm. My question is, where are there still gaps? I guess, like once these regulations are go into effect, do you see places where there are still going to be limitations, where there are still going to be manual prior authorizations submitted?
Yeah, and I think, well, maybe what we just do is talk about that scenario we went through in the lens of the digital world, and you can see what's changing and what's not. So, okay, whereas before that clinic has to go through and figure out, is prior auth needed and what type of information do I need to submit to have a successful request for prior authorization? And they had to do that manually through some type of faxing or website or something like that. Now they can leverage these APIs and through their EHR in the future be able to say, okay, we want this procedure. First of all, tell me, does it even require prior auth? And if it does, tell me what are the specific details, like certain notes or lab results or whatnot, that I need to provide to be able to successfully submit that prior auth. So that's an improvement in having the information at your fingertips through a publicly accessible API that should be well known to you for your payer partners. Then looking at, okay, now I'm going to submit this request. So it's not about figuring out, is it a portal, is it a phone number, is it a fax? No, it's through an API. Most likely you'll do it through your EHR because the EHRs will have to support that. So now you've got the centralization and the standardization of how you go about submitting that information. Now, with that, now you're going to look at, though, a process happening where the information has been placed into the payer's hands, but they still have to go through their decision-making process and their, essentially adjudication of this request to see, do I want to pay for this or not? Do I feel that it's medically appropriate and within the coverage that's available for this patient? That is not changing for the most part. I think we can talk about, Sam, some of the changes around like the SLAs. Maybe you can shed some light on that in a minute, but the fact that the payer still has to review this and go through their process, and most likely, at least for now, having a human review that is something that's not changing here. So there's still going to be that frustration. There's still going to be that turf war again between the provider and the payer when it comes to making that judgment of medical necessity. Now then, to get that response, to be able to know if it was approved or denied, as well as to be able to communicate that information to the patient, that should get better with these regulations that have been proposed. So now we can have an API or some sort of similar mechanism for the office that made the request to know, hey, this has come back with a decision. And then also, you mentioned how the name of that rule from CMS was patient access and prior authorization. That's because there's a patient access element to this. The existing APIs that are already required by CMS to give patients the ability to access their medical records through payers, that is being enhanced through this new regulation to say, in addition to that, or that has to be built upon, and you have to include information on prior authorizations and make that available through that API. So now folks who are using an app that's connecting to their payers to be able to pull down their medical information and the information their payer has on them, those APIs that are being leveraged through that app will be enhanced by, January 1st, 2027?
2027.
To be able to include that prior authorization information. So there's greater visibility and data access for us as patients.
Yeah. So there's a lot there.
Yeah.
So, maybe to kind of summarize, the big changes that we see out of these two new pieces of regulation are that from the provider's perspective, right, when a patient is clinically appropriate to need care, the provider can now, via APIs, so the provider's health IT, I should be explicit.
Sure.
The provider's health IT can now make an API request to a payer's health IT and determine whether or not this particular procedure or service is requires prior authorization or not, one. Two, whether or not, or what the documentation requirements are for this particular service or surgery or item for this particular payer, which again, like, can vary widely,
Yes.
which is why this is such a hassle. And then finally is able to actually make the prior authorization request, receive a response, and then patients can check the status of their prior authorization through their own patient portal.
Yep.
That's a lot there, and that's quite powerful.
Yeah. And that's why these rules that have come out are quite lengthy.
Right.
I don't know what the exact page count is, but they cover a lot of detail because there's so many aspects here. There's a process aspect. There's the technology aspect. There's even a incentives and reporting aspect, which we haven't talked about yet. But some of this stuff feeds into how providers are incentivized and compensated through the Medicare program. So it has a big deal in terms of the dollars going into their pockets.
Yep. And you mentioned the SLA changes. So even outside of the technological requirements here,
Yes.
there is also a new requirement on, again, impacted payers. Payers that are overseen in some way by Medicare or receive in some way Medicare reimbursement. They are now going to have to respond to prior authorization requests within 1 week if it is not flagged as urgent, or within 72 hours if it is flagged as urgent.
Yep.
Right. So this is a big deal. It kind of remains to be seen to some extent exactly how that is going to be enforced. But that is now the requirement of these payers.
Absolutely. So big changes.
Big changes, and really exciting.
Yes.
So let's now go through and kind of highlight where are there still gaps. So we talked about the impacted payers, right? So private health insurance plans, so primarily health insurance plans that are offered by employers, employer-based health insurance, do not technically have to comply with these requirements.
Right.
That's a significant portion, and probably a number of people, watching this. You may receive employer-based health insurance, and if that's the case, your employer may or may not actually comply with these electronic prior authorization requirements. Now, historically, often when CMS, lays these kind of stronger regulatory requirements, health insurance plans will comply preemptively, particularly if some of their, health plan verticals are required. They may just go ahead and support these requirements for all of their health plans, but there is no requirement. So that's something to keep an eye on.
Right. It's like the startup costs are already there, whether you're doing it for one plan or a bunch. Not saying that there aren't additional costs as you broaden that reach. That's absolutely, still a factor. But hopefully they kind of see this as, hey, we already had to do like 75% of the work or 60% of the work. It's worth it for us to go ahead and make these things available for all of our plans. That's our hope. But again, no firm, stick from the federal government to force them to do so.
Yep. I think the other thing I want to talk about, I think now is the point where we're probably going to dig a little bit deeper into the weeds.
Sure.
Right?
Yeah. So I think we cover like the high level and things like that. So what do you want to nerd out about?
So what I'm concerned about is the specific FHIR spec, the API FHIR spec that is required to be supported by the health IT. So the payers side, the providers side are required to support these.
The providers, health IT, the EHRs
are required to support these very specific implementation guides that are API based, are FHIR based. The payers side, the impacted payers side, their health IT is not necessarily required to support these nuanced implementation guides. It's recommended, but it's not required.
Okay.
And there are some complicated components of these guides, right? The prior authorization has a lot of nuance and a lot of complexity, and so these FHIR implementation guides also have a lot of nuance, a lot of complexity.
Absolutely.
There are things like what are called FHIR questionnaires, which is a part of how the documentation requirements are communicated. There are these clinical quality language, CQL. So some of these guidelines are quite nuanced, and that's something that was a concern of certain entities that submitted comments during the proposed rule segment of these regulations. I know this is word salad going on here.
Again, if you really like nerding out on federal rulemaking, this is your jam.
Yeah,
So.
exactly. So my question is, like, do we think that, and this is kind of conjecture at this point, but do we think that impacted payers will actually comply with these nuanced implementation guides, which kind of would be required in order for this electronic exchange of prior authorizations to work properly? Or do we think that they'll take some shortcuts that allow them to check the box, but doesn't actually get us much closer to the electronic exchange of prior auths?
Yeah, I mean, I think there's a real chance of shortcuts, and again, understandably so, given the challenges that we face with having to comply with the specific IGs. I think there are folks who are heavily involved in this process and heavily invested, and will probably conform to those implementation guides in large part. These are people who are involved with the Da Vinci work group, which is one of the FHIR accelerators that focuses on value-based care and payer-related workflows and supporting those through FHIR. So these implementation guides that you're referring to, Sam, I think are Da Vinci, origin.
Yes.
They're Da Vinci implementation guides. So folks who are involved, the bigger payers especially, they're probably going to comply there. But you have smaller payers and independent plans and nonprofit plans, things like that are going to have a harder time or may not be as caught up on the IT side. They're also likely going to outsource some of this work to other entities. They're going to have to figure out, like, how do I take all my data and put it into some type of format or mechanism and build an API on top of it? Well, I don't have the expertise to do all that. I'm going to outsource to a third party who can take some of that data and basically stand up those APIs for us. And as long as that third party, I find somebody at the lowest cost that will check the box, then yeah, there's a possibility that folks will take shortcuts. We saw this before. We've seen it. And this is not, again, it's not meant to be critical or anything. It's just to try and, provide objective perspective. I'm going to talk about a slightly different topic, but when we were in the early stages of interoperability and federal regulation and interoperability back in the meaningful use era, for those of you with the experience and the scars of health IT for those years, there was a portion of meaningful use stage 3 where there was a requirement to offer APIs for patient access, essentially, to allow patients to through an app of their choice, access their medical information across a certain set of clinical domains, medications, allergies, problem list, immunizations, things like that. And so that core common clinical data set is what was required to be accessible through APIs. But it did not say FHIR APIs necessarily. And so that was where the EHRs had liberty to be able to do things in certain ways and choose certain APIs to make available to satisfy those requirements. So yes, people will take shortcuts if push comes to shove and they don't have the opportunity to comply with those guides. And 2027 sounds like a long way away, but it's not just conforming to the guides. It's also about doing all the other things to make it possible to offer these APIs, like the coverage, determination and the documentation requirements that you need to be able to offer and provide through API. Some of this information lives in Word documents and Excel spreadsheets. Like how are you going to make that to where an API can read that? I never tried that with ChatGPT or any other AI product. I'm not sure how well it would do, but that stuff is going to have to be aligned and standardized and normalized to some type of database or other repository that the APIs can then look to be able to serve up the correct information.
Yeah. So yeah, a lot to follow. The other kind of more nuanced question, this is not necessarily about the exchange of data, but in terms of the requirements that are levied by these regulations. The HTI-4 rule doesn't actually make these prior authorization requirements of providers' health IT a part of the EHR's core definition.
Okay.
So technically, the health IT used by providers are not required to support these if they choose not to certify to these criterion.
Sure.
ASTP has called out that is something that they're considering doing in future.
Mm-hmm.
And there are still financial incentives on the provider side to use health IT that does support these electronic prior authorization flows. And that also, again, will go into effect 2027. But that is also, like, in theory, there could still be health IT systems on the provider side that choose not to support these requirements.
Yeah. So what's the saying? If it walks like a duck and quacks like a duck, it's a duck. Well, if it walks like an EHR and quacks like an EHR, it's an EHR, but only if it meets the stricter definition by the federal government for the purposes of these rules and regulations. And these prior auth certification standards and APIs and such, you're saying, is not part of the whole quacking like a EHR.
Right.
So,
and now you may have heard the term quack like an EHR a little bit too much.
It's a pastrami, sorry.
Right. Again, this is a hypothetical scenario.
Yeah.
Just to be clear for anyone watching, Cyrus is in fact fully healthy.
Yeah.
With I don't even know if he's had one pastrami sandwich yet in New York City, and after this conversation, he probably won't.
Yeah.
One other topic I wanted to talk about, there was an announcement. Actually, I think it was in the last couple of days. Abridge Health, one of the kind of AI documentation tools, announced that they were working on an initiative with, I believe, Highmark.
Yep. Mm-hmm.
to expedite the electronic prior authorization process, make it done entirely through like kind of audio communication, and kind of in some way like use the AI as like a translation layer to circumvent some of these like specific like data structure requirements. I'm curious to kind of get your take on if you see that, where you see AI as like kind of a translation layer fitting into these extremely strict data structure requirements outlined by these implementation guides.
Yeah, on the one hand, it's got some interesting potential to, again, help with the efficiency and the burden of prior auth. Imagine if you as a medical assistant in the clinic could be able to use AI either independently or integrated with your EHR, and say, hey, AI system, for this patient, we want to provide them with this procedure. Can you find out if AI system? Can you find out if prior authorization is required for this particular procedure, and if it is, what type of documentation is necessary? Then please go through the patient's medical record, pull together that documentation, and submit that prior authorization request to their insurance company. So by that prompt, a system that's smart enough and well trained enough would be able to take those steps based on that direction and eliminate a lot of the work and the labor that goes into this today. So that could be a huge win. At the same time, though, AI, you always have to train it well. It always has to, ensure it's doing the right thing. So how does AI know the right pieces of information to pull? Well, it might possibly miss something. Could it send something that it shouldn't send that maybe is not related to that service, that a payer then finds out about, hey, this patient has had this particular service or might have this condition, especially documentation that might be tied to services that happened while the patient paid out of pocket. You always have to be very careful not to send visits that are self-pay and data associated with those visits to a payer, because they don't necessarily have a right to that information. So that's one aspect there. That's like the submission side. Then on the receiving side, as that payer, Highmark in this case, well, what role is AI going to play in the decision-making process for evaluating that prior authorization? That's going to be really interesting to watch. I guarantee you heard it here, folks, first. Probably not, but I'm going to say it anyway. Payers will want to, and may even be to some extent, use prior authorization AI, based algorithms and systems to adjudicate these requests and make decisions. That could speed up decisions, no doubt. It could also mean that certain things are getting denied that shouldn't be. It could lead to, as we've noted already, a high rate of situations where things are getting denied when they're supposed to be medically appropriate, and when, maybe on appeal they end up being approved. So that's something to think about very closely. It's a common consideration when it comes to also approving things like the length of stay for a patient in the hospital, for being able to assess whether the patient meets inpatient criteria status when they're getting admitted to a hospital, et cetera, et cetera. So there's going to be a lot of scrutiny, I think, if you see payers utilizing AI to be able to assess the validity of the prior authorization request and to make a determination.
Yeah. On the other hand, just to paint maybe the slightly rosier side here, you could imagine a world where, AI on both sides of the prior authorization process are kind of exchanging, again, in this rosy picture, legitimate information that both sides should have access to, and a prior authorization. Hey, like, have you tried this particular medication before you requested this one? And that exchange could happen instantly, more or less. And so you could imagine some of these potential appeals being expedited. If you're able to identify if the AI on the payer side is able to identify what the flaw is in the initial request, and then make that clear to the provider side. So I think there's so much to unpack here, and there's so much that we still don't know at this point.
It's very early. I don't know that we have this, fully baked, and I haven't seen it, fully implemented in the wild, but it's going to happen. Like, we're going to see people pushing the envelope and trying new things. And hey, we love that. We love the innovation, but let's make sure it's done in the right way and it doesn't, cause detrimental effects for anybody.
Yeah. Great. Well, Cyrus, anything else that you want to highlight? Any people you want to shout out?
Shout out my doctors here in Brooklyn who have been very helpful with the Prashamiitis. No, I think this is really interesting stuff. It's really cool. Again, the potential that we have for transitioning prior authorization to the digital world is really huge, and it's something that everybody should be excited about. I think regardless of how you feel about prior auth, it's the right step to take. It's not perfect. It has the gaps we talked about in terms of the payers. It has the gaps in terms of, the process of prior auth still needing to be something. And it's worth mentioning too, actually, sorry to slide this in, maybe it's a little nugget at the end. A lot of the focus here, in these regulations we're talking about are really around procedural-based prior authorization. So medication-based prior auth, which is very common when it comes to expensive drugs in oncology, in rare diseases, et cetera, those are things that are not directly covered by these rules. And so as a result, you still got that whole area to focus on and that gap to fill. But all of these things are things that make it imperfect, but progress. And I think that's really important.
Yep. Great. Well, pleasure hanging out with you. And I think I'm going to have to drag the mic away from Cyrus. Otherwise, he's just going to keep pouring wisdom and knowledge into the microphone forever and always.
Well, I'm in the one of the homes of jazz and entertainment in the world. So when you've got a mic in front of you got to show off for the folks. I might end up on Broadway one day if I keep trying.
That's right. All right, thank you all for listening. We'll see you again soon.
See you later. Thanks.